Good morning, distinguished colleagues. We have heard Dr. Trung present about very severe stroke. Now I'm here to bring you to a very entirely opposite clinical spectrum, mild stroke. So this is a very important and challenging topic because this population of patients largely excluded from very major randomized controlled trials and leaving a very significant gap in our baseline evidence. So it is a very privilege to present our work to all of you entitled Efficacy and Safety of Endovascular Thrombectomy Compared to Medical Management in Patients with Mild Stroke and Large Vessel Occlusion. I have nothing to disclose. I would like to start my presentation by telling you a story. This is a male patient, 63 years old, sudden onset of right side weakness, last known well 6.5 hours, with his NIH score of 3. This is a mild stroke by definition. This is his imaging profile, no hemorrhage on the CT scan. The CTA show M1 occlusion, and this is a large mismatch on perfusion imaging. Despite this severe imaging, the clinical physician still put the patient on medical treatment, and unfortunately, the patient deteriorated dramatically after 24 hours, and at 72 hours, his NIH score of 9. The patient hardly moved the right side of his body, and upon discharge, the patient was wheelchair bound. So this raised a clinical question. It is stroke is too mild to treat, or we just missed the critical therapeutic window. So that's why we conduct our study. According to literature, 66% of all stroke patients have the NIH score of 0 to 5. 10% of that 66% have LVO, and 23% of that 10% may demonstrate neurological deterioration that require rescue therapy. And until now, we still have a lack of evidence of EVT efficacy and safety in this population. So our study aims is to investigate the efficacy and safety in EVT in mild stroke with LVO patients, and maybe we can identify some favorable outcome predictors. This is a single-center observational prospective study, included minor stroke, ischemic stroke patients with large vessel occlusion, include ICA, MCA, M1, and M2. We conduct from June 2022 to May 2024, including 140 patients. In that, 41 patients undergoing thrombectomy, and the other 99 patients receiving medical treatment alone. The primary outcome was MRS 022 at 90 days. Symptomatic intracranial hemorrhage and death. Secondary outcomes were the recurrent stroke rate in 90 days, early neurological deterioration rate, and outcome predictors. As you can see, both groups had comparable baseline characteristics, except the EVT group seems to have more severe patients than the medical management group, and more patients with M1 occlusion. Another baseline characteristic worth mentioning is that the EVT group seems to have a better mismatch profile than the medical management group. That means the EVT group had larger penumbra. And here's come the result. The MRS 022 at 90 days in medical management group is about 78%, while the proportion in thrombectomy group was 75%, and this difference is not significant. For the safety outcomes, the EVT group had higher symptomatic hemorrhage rate and more death. But I have to clarify here that the 2 deaths in the EVT group had nothing related to any neurological causes or such procedure. And you can might notice that early deterioration also a little bit higher in the EVT group. But one fascinating finding in our study is that there are almost no recurrent stroke in the EVT group, while this proportion in the medical management group almost 20%. And this is significant difference. We try to, when we do the subgroup analysis, we try to exclude all the patients with no mismatch profile on our population. So the EVT group got 40 and the medical management group got 63. And finally, we find some positive sign. Finally, maybe we go to the right direction. The MRS-022 of the EVT group a little bit higher in the medical management group when we use the perfusion imaging. And again, there is no recurrent stroke in the EVT group. So our study have a considerable proportion of patients had cervical IC occlusion, and nearly 40% of the EVT group patients only got poor reperfusion. So that may suggest chronic occlusion in this patient population. And collateral status was significantly better in the medical management group. That may clarify why low rate of early neurological deterioration compared with the EVT group. On multivariable analysis, Tmax 4 seconds, Tmax 6 seconds, NIH score at discharge, and absence of recurrent stroke independently predicts a good functional outcome with a very excellent model performance area under the curve, nearly 0.9. Our study also have limitation, small number of cases, lack of randomization, decision-making based mostly on physician and patient relatives. There are no rescans after 24 hours for every patient, heterogeneous angiography, and 90-day follow-up may be too short to detect any recovery from the stroke and to detect recurrence rate. So, colleagues, mild stroke with LVO does not always benign causes, and EVT timely can resolve functional outcome and prevent devastating recurrence. So what we need to do is to look beyond the NIH score and look into the brain imaging perfusion so we could find which patient will truly benefit from EVT. Thank you very much for your attention.